So Stacey brought up a good question. Like, are there any guidelines where you would use mobilization over manipulation? When I started to realize what was going on, or what I thought was going on, I thought back to an old saying, and nobody is quite sure where it came from or who made the original statement, but it goes that evil can only exist when good men do nothing. And that is so true. Except it should be good men and women. And when I looked at that, I thought, long-term joint dysfunction can only exist when good therapists have done nothing. In other words, there has to be a point. If this theory is good and holds true, there has to be a window of opportunity where a mobilization would not allow that chronic facilitation to cause maltracking. The trouble is, in our society, all too often, we have an injury, we go to a physician, he puts us on anti-inflammatories and pain meds, and that can go on and on. Because I think the window of opportunity is probably, and I use this only because I'm thinking back, I think it's probably in the first 3 months. Early mobilization, and that's what we were experimenting with in my rehab clinic. You keep pestering the patient. Can you move yet? Can you move without pain yet? Even that much? That's fine. Just that, I'll take that. As soon as they start moving and they get less pain or movement, keep following. Through all movements, even the quadrant movements. Because basically in nature, we wouldn't have the luxury of not moving. In nature, when you get injured, you either get moving or you get eaten, or you starve to death if you're a predator. There's no medication, and there's no sympathetic hugs. We've forgotten that. We've forgotten that the rule of nature is keep moving. Now, obviously, there are certain conditions where to keep moving is going to make things worse. We have to be aware of that, and we have to learn that. But we're talking about a simple, relatively simple, articular damage with muscle guarding. If I had evidence that I had a rim lesion, the last thing I'm going to do is early mobilization. I want the thing to get tight, scar over, and get stiff. Because what's going to happen, and does happen, when they get pushed, they seem to push the wrong people into early rehab. They take these people and say, oh yeah, they need exercise, they need daily pool therapy. And nobody's noticing that they're not getting better from all this exercise. They're getting worse. They're getting weaker. We're doing the wrong thing. So conditions like that, same as fractures, there's got to be a period, a much longer period of fixation and immobilization. But in these guys, ones that have a relatively simple but non-serious injury to a segment, I think the sooner we get onto mobilizing them, the more likely we are to prevent this long-term functional hypomobility. Now, I'm saying 3 months because that's officially the line between an acute lesion in terms of time and a chronic lesion. They give you 3 months based on tissue healing. So just keep that in mind. If you've assessed somebody and you're picking up what looks like a relatively moderate injury, but they can't go this way, okay, that's fine. We don't want to push them because their muscles are not ready. But we keep encouraging the movement gently, not through pain, always pain-free, But keep pushing the barrier. That's what I would use, and that's what I did use in the clinic, in the rehab clinic. I had an orthopedic clinic and a rehab clinic. And the rehab obviously had to be far more activated. So we were always looking for ways to get people mobile more quickly.
Visit us at ASPIREOMT.com.